Healthcare has seen rapid changes over the last few years, with both the government and private players leading the transformation. But there is also a realization that to talk more on the subject, we have with us today Dr. Rajendra Pratap Gupta, founder internationally. Dr. Gupta, good to have you with us.
My pleasure. Thanks for having me.
So let's jump right in. And my first question to you being that India is now the world's most populous country. What does it mean, especially for the healthcare system?
So, from very interesting question and a very loaded one, and I expected that. Being a populous country, you have to see in terms of long-term planning. So, how I look as a policymaker is that we are today most populous country. Now there are 2-3 standpoints you need to look at. Within the most populous country, 65% of the population is below 35 years, and that gives you an action area. In 2047, we would be 1.6 billion. We would have 1 out of 5 person as senior citizen, which is going to be a good 300 plus million. Now, when you look at these two numbers and you look at 440 million children, I think the choices are absolutely clear. We are still a lower middle income country. We are not a middle income country. And that too, if you look at our entire statistics, we are in the lower rung of lower middle income countries, not even in the middle rung. So with that, it becomes very clear that let's focus on the important along with the urgent. So child health should be a very high priority area. And when I say this is, if you do not manage them well, we will run into serious issues. Just imagine 1 out of 5 being a senior citizen and we have to fund their costs, they have no income. So issue of productivity, issue of fiscal deficit will be the twin-headed monster that we will not be able to handle. So when I look at a vast population, I see a phenomenal opportunity that we have a huge chunk of youth population. I should keep them healthy, make them invest in a health saving account so that should they grow old and be unhealthy, that corpus can help manage their needs when they are not having that income or that level of social security. So I think from that standpoint, I see this as a great opportunity for India. Not much of a worry now, but the worry compounds every year because the senior citizens grow 3% every year, and every year we become older. And I wouldn't like my country to become, I would say old and sick before it becomes rich. And when we do become old and sick, we'll never become rich. So that's the realization we should have.
Interesting. So, healthcare in India is still largely driven by, a large part of it is driven by private players. What role do you think is there for businesses, especially small and medium healthcare providers, in improving our healthcare system?
So this is a very interesting question because it addresses the point of healthcare delivery. And if I look at it, I would like you to think about, you have very clearly demarcated a question making my job much easier. So one is private and the other is small and medium healthcare organization. Now in terms of private, look at any large hospital chain in India. They are funded by private equity players. So that means there is a lot of foreign money in healthcare. Good because they will expand. Bad because a private equity player will look at a PE ratio, which is price to equity, IRR, not patient reported outcomes, not PROs. So in that way, it sets the context that we have a challenge we have not thought through. Who is funding the large players? If they are funding the large players, like in times of COVID, it was mostly the government players, who helped and chipped in, not exactly the private ones. And those who got into, we know the stories. I think as a journalist, you understand the pain that we saw during COVID. So that's one part of the problem, and we got to address it. And we recently did a national workshop virtually on small healthcare organization. I would not even look at medium, I would look at small, less than 50 beds, because that's where 80% of India's healthcare get delivered. Large players wouldn't get into smaller towns, rural areas, because it's the issue of people not being in a position to pay the prices that they would ask, being the big brands, being their cost that they would have. So it brings the focus back to small healthcare organizations. organization. And that is where I think as an organization and as a think tank that I run as a part of my organization, we are very focused on seeing how do we take small healthcare organizations to the point of viability. And most of the small healthcare organizations have 5 major issues that are becoming a crisis of existence for them. In smaller cities, they are shutting down. So if we really want to make healthcare in India affordable and accessible and of an assured quality that people should get, we need to think of a model where large number of small organizations deliver healthcare rather than small number of large organizations. And I've told you that it's PE funded for large. In small, I think the government has to chip in with viability gap funding, because that's the only way it can. They have to assure them of a corpus, maybe adopt a health management model so that they give them, okay, in the communities you serve, here is a corpus, keep people fit and healthy. If they fall sick, take care of them. That's how people will invest. But they should be ideally small hospitals who can then attract talent, retain them, and also keep people healthy in their places. I mean, I find a lot of people coming from smaller towns and saying, I have come to Delhi, please get me names, please get me here. I think that's not going to help our country. So I think you have a very right question, and we need to focus on small healthcare organizations. Government has to come up with schemes, give them viability gap funding. They can't hire senior people. We need to find innovative cooperative models. So that is where the answer to making India's healthcare self-sustainable and viable, and I would say outcome driven for the people of India and for the government, which remains the largest investor today.
Right. But at the end of small, big, whatever the chain size maybe, how is the twin objectives of business viability compared to a high quality and affordable healthcare?
So yes, it's a conundrum. If you really ask me, viability versus quality, but this is where innovative financing has to chip in. When I'm young, I can give you a small amount of money in a health saving account, and that's my corpus. Should a ailment strike me, I can be helped with the corpus I submit. So we need to look at innovative financing so that whether you have a short-term strategic tie-up like the National Health Policy 2017 talked about, or you have an insurance scheme. Otherwise, for smaller organizations or even large, the medical equipment and devices have the same cost. An MRI machine would be 5-6 crores. So you got to look at attacking this issue from a very different standpoint. So how do I make medical devices affordable? And thankfully we have the medical devices policy that has come in. It'll take few years to settle down to have our indigenous devices. So we'll have to make sure that the cost of treatment is low, and at the same time there is enough cushion built in, and there are standards which are driven by something that I have not seen people talking, and I have personally written that line in the National Health Policy. It is that both the private and public sector facilities have to mandatorily disclose the treatment and success rates. For me, that's quality. Having NABH or JCI is not quality. I think most of the people in India would not understand these logos. These probably are marketing logos. You put them fancy logos, people walk in saying, oh, we are JCI accredited, we are NABH accredited. I don't think NABH has ever done an accreditation as a study on what's the impact on quality. I've served on the accreditation committee for a number of years. So for me, if you talk of quality, that is, you got to make patient reported outcomes. Now that we have NHA, we have coming to Aadhaar numbers, rolled out 35 crores. So we will have actually data of patients. Let's look at facilities. Let's look at what their outcomes. So quality will be that. It should be of a minimum quality. Then I think we also need to think about, do we let people charge what they want? Is it the best way? Healthcare is not something that is an aspirational, or optional thing. No one is forced to buy health. No one has a choice. If you find 10 hospitals, you're going to buy when to go to a hospital. So I think the pricing models have to be also looked at. So I would strongly encourage activity-based costing. I would strongly encourage reference pricing for drugs. So in an ailment or in a disease condition or a medical condition, the price points can be between this band. So this will bring a lot of sense to payers who are still, I think, 45-50% based on the latest studies that I know, which is huge. So viability can happen if government starts looking at it. I think there is a serious crisis I see on the horizon of private equity players funding. That means viability is already a foregone conclusion. It's not there. Let's be very clear. When you get equity investments, you're looking at expansion, growing valuation, someone coming, exiting, making returns, someone else coming. So those investments have also led to, we know the situation of some of the hospitals in this country, even large ones. So I think government has to chip in to look at AIMS model. We are actually working on a report will come out. So AIMS has a private ward, AIMS has a general ward. So that AIMS Delhi model tweaked in a manner which is also in line with the national health policies, very clear line that's written, based on the ability to pay. So open an AIMS in every district. So AIMS like institution, I'll not call the word AIMS, that gives a wrong sense to people, where there is a private ward and there is a public ward. Anyone who wants to use the expertise of a doctor in an AIMS like institution pays based on their ability to pay. So we subsidize. So in this manner, we can keep the viability part going. We can also keep the quality out there. So I think we cannot have those things, of strategic purchasing as a long-term measure, which I think I clearly written, be a short-term measure. Otherwise, if you get into a strategic purchasing as a long-term measure, we'll go the US route. These big players will become so big, they'll influence the government to tweak policies, and the end game would be users would be losers. The AIMS like model on one side, based on the ability to pay, you have a private ward, you have a public ward, or the general ward I'll call it. It's cost subsidized. You have an insurance which takes care of it, but the pricing also is activity based pricing and the reference pricing. So I think you require 2-3 approaches, and there could be more models too. But overall, I think handing it out to private players is going to take away both the viability and quality. I would personally believe that.
You mentioned that as well, that you see a lot of patients talking like Delhi when in healthcare. How do you remove the regional disparities that exist when it comes to healthcare? Also, have we addressed issues like our primary healthcare system, secondary healthcare system? Is it that everyone's running to your bigger hospital chains even with a flu?
Very true. So let's understand India per se, and if you look at those 6 states of Bihar, UP, Rajasthan, I think it's Jharkhand, Chhattisgarh, Uttar Pradesh, they account for almost like 42% of the population and 56% of the increase. So where exactly you got to invest. If these 6 states are taken care of, our national indices will come down. But I still think that the point you have made is a very intelligent question, that disparities. So if we want to address that, in the national health policy, you will find that we have not talked about beds to population. Specifically, it is written, and this is something that I was very keen on, the golden hour rule. When if everywhere we are talking of a golden hour rule, why should the beds be on the population or distance? You should get that care in that 45 minutes, 40 minutes. So policy from a standpoint of giving a direction has addressed that we should be from a golden hour rule. But it is easier written than done. Let me also confess that. See, as a nation, we are fighting too many battles. Our Prime Minister wants to bring development fast, so we have to invest on infrastructure. We have to look on education. We have to invest on healthcare and defense, given our geostrategic position right now. So in that case, if you look at the other side of the number, we are now producing 1 lakh doctors. 1 lakh doctors a year, undergraduates. In next 15 years, we'll have surplus doctors to population. What WHO numbers tell us. So on that side, I'm pretty comfortable that there'll be more doctors than we need for the population that we have. And equally, I think technology would have become scientifically robust to replace some of the roles that doctors play. So I'm pretty sure that healthcare delivery inequities will be addressed thanks to this increasing number of human resources plus technology becoming, evidence-based, advanced and accessible. It's getting cheaper by the day and more advanced. So for next 10 years, I think we will have this issue. But the disparities still focus on the 6 states, as I would say. And digital technologies are very important. You also asked this question about the primary, secondary and the tertiary. So, digital health is a solution for some, is a platform for many. So today we both are talking because we are connected seamlessly from wherever we are, and we are doing the same thing we could have done face to face. Yeah, no one would come to know if we didn't tell that it was online. Now, fact being that if we use digital health, we have a 3-layered system: the primary, secondary and tertiary. If we make a 4-layered system on one side, give people access to information and primary care on their mobile phones. E-Sanjeevani has done now 95 million consultations. If we made sure that everyone has access to an OPD consultation as and when they need, because every district has a doctor, they can be mandated to spend X minutes of time, giving online consultations. I think the most of the problems in primary care would be solved. That would stop people taking the precious time of a doctor in a district hospital. That's one part. We have all focused on primary prevention. We have forgotten that, as most parts of the world, our prevention starts when the first intervention has happened. So when you get hypertension, you start thinking about diabetes. When you get diabetes, you start thinking about kidney failure. So both primary prevention and secondary prevention has to move towards technology enabled. And I think that is where India's forte now remains. We have been the tech capital of the world. We need to transfer that capability into health. So on one side, the growth of medical professionals is pretty fast, and I think is as more than what we need. Next 10 years, you will see we'll have excess doctors. We'll think 1 lakh doctors, would have put 1 million doctors. That's the number we have for the last few decades. And then it will be every year adding. So we will be exporting health professionals outside to the rest of the world, which is a great thing to do. It's a great health diplomacy tool. But on the other side, technology would be doing a lot of things. I foresee intelligent electronic health record on my mobile phone, where I start saying my medical problem. It is embedded with the DSS. It starts telling me, okay, Rajan, you seem to have fever. Please take this medicine and report back in 4 hours your vitals. And when I go back to it, it says, I think it's working. You don't need to worry. So most of the things that at primary level the doctor does will be clinically possible using smart technologies. So I think the divide is going to be remaining for next few years. But our investments that we have talked about in those 6 states and the government's commitment of increasing it to 2.5%. So I think by 2025 may be a bit difficult, but we are on that path.
Right. So, health outcomes are a product of many factors. It is beyond just the healthcare itself. It is set aspects like education, income, and the physical environment also plays a big part. How important is this in Indian context now?
I think for every part of the world, these are deciding factors. If I don't have money, I'll postpone a surgery. If I don't have money, what kind of prevention are we talking about? I'm going to run pillar to post to make my 2 ends meet. If I do not have education, even if you give me the information, will I be able to assimilate that? Will I be able to act on that? So historically, education, income and environment have played a key role. But now that we have a new social determinant of health, and that's what I think we should all look at. We have to factor them, is the influence of social media and internet technologies. So there is an excitement for adoption, but there is a worry for addiction, I would call it. Now, all of us are used to sitting on the screen. I'm sitting looking at you, making sure that I'm doing this interview well, but my C4, C5 is under the strain. All of us work. So eventually I see a lot of disorders coming because of internet. There will be mental disorders, there will be ophthalmic disorders, there will be postural disorders, and this will have a huge impact on productivity. So there are those determinants, there are those social media, and the other side. Earlier we used to say one is Bharat, one is India. But in terms of information technology, there is only one India, and that's aspirational India. I have gone into villages. They see the same things that you see in Delhi, that I see in Delhi. Now, that is also has an impact because we are using the social influencer marketing. So a lot of things get pushed to the common population, and we have seen debates about the sugar levels in some of the health drinks and all. So the impact of this media is that we are consuming a lot of things which are unhealthy, whereas the lives are getting mechanized. So a lot of metabolic disorders, obesity, diabetes, hypertension, even cancer would be a result of this. So I think it is multidimensional, and beyond a point, if you really look at the national health policy, it talked about hygiene, sanitation, the Jal Jeevan Mission, providing electricity to people. So I think from a government standpoint they have done, but it is, I think, cannot be left to just government alone. Health is multidimensional. It is beyond those old paradigms of education, income and environment. There is an element of social media and internet technologies. We have to think about them as well.
Your answer itself, makes me wonder that is it the case that there is no one organization, one sector that is totally responsible for improving healthcare outcomes? Uh, does this mean that India needs more multi-sectoral partnerships?
Yes, that's true. I think of the broader vision of the Prime Minister is talked many times about Jan Bhagidari. I think health has to be people's movement. If I find something that I am seeing in you and I'm seeing you doing which is not healthy, I should be first educated enough and I should be able to show every individual, every family, every organization, every state. Health is still a state subject. Has to get involved, has to identify their own challenges, their problems, and they differ from state to state. So it has to be a people's movement. It has to be a multi-sectoral collaboration. Like during my tenure as advisor to Health Minister, we came out a booklet with the Ministry of HRD, which was for school children. Like, what do you do, in terms of 10 things that children should look at, and it was visual. And I think now environment, One Health is a big issue. If you look at last 20 years, most of these outbreaks came from animals. So animal husbandry. You couldn't have ever thought about it more than 2 decades back. And now, as we say, no one is safe till everyone is safe. You can't do it from Health Ministry alone or Pharma Ministry alone. And then, as they say, outbreak is not an option, but pandemic is a choice. You can always prevent it. And how the paradigms have changed. Earlier we said during pandemic we learned that united we stand, divided we fall, and during outbreak we said maintain that distance, united we fall, divided we stand. So I think a lot of things have shifted thanks to COVID. It has also brought the focus back to the fact that health has to be a priority for each one of us. All those who have COVID are also going to see the long impact of COVID. It will have to be taken up by everyone in this thing. It cannot be Health Ministry alone, it cannot be government alone, it cannot be India. I think it's a people's movement, and it is not only multidimensional but multi-sectoral.
Right. Health and healthcare in India needs to reach a level where wealth and income inequities do not determine the quality of care. Of the people's movement, India's vast healthcare system will have to quickly iron. Thank you so much for talking to us. It was a real pleasure.
Thanks for having me. It was a pleasure talking to you.